Our first speaker of the day is Dr. Aparna Jairam. She is representing APPI and is in the organizing committee since the last 3 years. The APPI represents the voice of pathologists in India. Her team won the recent election by a thumping majority. She is the Chief of Operations and Immunology SRL Diagnostic, Dr. Avinash Phadke's lab, Mumbai, India. Her special interest is in the field of immunology, autoimmunity, microbiology, and molecular biology. Ma'am, will you please come on the stage? And today she is going to deliver her talk on understanding test interpretations.
Good morning. Kem cho? That's expected. Thank you. Thank you so much. Thank you, Prashant. Yeah, what I thought is definitely without taking much time, because it's a first lecture and as Madam introduced very nicely, when we arrange conferences, the most dangerous lecture is the first and the last. So you have to either make it very good or people walk out to the breakfast session. So I would like to see you all at least bear till the time I finish. And to make it interesting, I felt we should take up some challenges or some cases I guess every one of us go through in our day-to-day practice. So I have taken up some sample cases which may be from my lab or from other labs who are referred to me for an opinion or how to go about this case. Yeah. So. Yeah, I would like to start with, is this audible? Yeah. So we have one case, okay, lights. Yeah. Yeah. We had a case of 55-year-old male presented with history of PUO. There was no lymphadenopathy or organomegaly. The reason I mentioned this, thank you. So after that, these are summary of investigations which we have seen. Basically look at the WBC count, elevated platelet count, borderline bilirubin, ferritin, okay, and clinician had also asked dengue, which I have not mentioned here because the platelets were high, so I thought I need not mention that here. EBV IgM negative. Okay. So as Madam introduced, I have a keen interest in autoimmunity and immunology with, with that liberty of running extra test when I want. We did this EBV avidity profile after doing EBV VCA IgM, and this is what we found there. Look at this. We had EBV VCA IgG positive, urea treated positive. So that means, a long standing infection. EBV VCA IgM negative. Now what is interesting is this early antigen. If you can see, those who can appreciate, this is EBV EA, early antigen positive. Now how does this happen? Actually, this is just the summary of that particular interpretation of EBV VCA avidity which I share with my clinicians. Is generally they have this habit of asking EBV VCA IgM ELISA. I am not saying that's not the right test. What here we are trying to talk is we are working in a diagnostic field where all of us will have to extract that particular clinical history from our clinicians and the patients. Just giving away a report of EBV VCA IgM ELISA would not have helped my doctor or my patient. After talking to him and finding out, we suggested that look, actually we had already done this EBV-VCA avidity panel where EA was positive. So this is basically showing reactivation of a past infection. So possibly that's the reason this test was helpful in this particular patient. So completely, now we have asked our clinicians to ask for an EBV avidity panel rather than asking for just an EBV-VCA IgM single, because if the patient is not fitting into that phase of infection, you or the clinician may be misguided for that particular infection. That's why I thought of including this case here. Yeah. Now this is the second case where it's one of my favorite cases. Again, this was referred to us as multiple sclerosis case, where patient had ANA homogeneous 2+ and complaint of on and off treatment of steroids. Patient was not very sure, and then later on query blurring of vision. Once the history of blurring vision comes nowadays, it's very clear that okay, you need to do NMO or aquaporin 4. But I want to stress here pre-analytical errors or analytical rather than pre-analytical, analytical phase of error. That's the reason I thought of taking this. Very interesting. We advised after ANA positive, patient was not, she had been to 2-3 good referral setups, was admitted in one of our known setup, and the clinician was very interested in talking to us and finding out what's wrong. So we advised aquaporin or NMO. It came out to be negative. If you look at this slide, there is no, I don't know if you can see because of these lights, but yeah. So there are some images in the picture. We thought that there is some problem because it was not fitting up, because we did oligoclonal bands of that patient and we felt somewhere that no, this is NMO, and trust me, it was negative in one of other good referral lab. So what we saw is we called in our technical expert from the diagnostic section of this particular company, and we got an NMO positive. So what I want to stress here is, and definitely those who know me, then they know me as a person who goes behind the clinicians as leech. So I go behind them, and that's what I found on MRI. Definitely we were, because first report was negative of NMO from our own diagnostic immunology setup, but we did not release that. We stuck to our diagnosis. We asked for oligoclonal bands of CSF, and we also did a repeat NMO with a proper technique, I guess, and it was positive, which was obviously coordinating with the MRI of that particular patient. So again and again we are going to, one thing is, we are just not somebody who is supposed to give a diagnosis, because many times when we sit in our labs, all of you will agree, and we say, Acha, what's the history of the patient? I think the first thing which maybe 60% of the time I get to hear is, you have machines, you have analyzers, give the reports. Why do you need the clinical details? Isn't it? No? Okay. I just wanted to be sure that all of you are awake after 2 sessions. So that I think what helps all of us is dialogue, communication, and if you don't get it, I mean, I have learned, just keep on following up with the patient or the clinician, and you can possibly add a lot of value and final, the diagnosis. And I think it's a win-win situation, because finally the business, because once the clinician believes you, he is bound to come back to you in a setup where they are going to get a lot of inputs to their cases and diagnosis. Now, this is the third case where clinician had suggested her PCOD panel. This was the panel where we saw insulin PP was slightly elevated, fasting was normal, prolactin was 128. Now, this is another thing which I thought I should get up in this particular panel, because wonderful thing to interact with our team of pathologists and microbiologists, because we face these challenges every single day, that you get a prolactin report from your lab as say 200 or 300, and obviously patients or clinicians don't like a high or an abnormal value unless they are expecting, and so the patient is not referred back to you but referred to somewhere else, and for your bad luck the report comes as 23 or 28 in another lab. Now what are you supposed to do? I think this is the challenge all of us face, and we know there is diurnal variation, there is fluctuation. You call up the clinicians, you tell him, but he is not bound to listen. So now what we have done is, I think most of us have done, is we stress on taking a tri-pool sample. I think that is not what I want to talk here, just end here. What we are going to talk about is there is lot of thing going about macroprolactin. I guess everybody is asking, at least I am getting couple of queries in 1 week, say 3 to 4 queries. Aparna, what is macroprolactin? Do you do macroprolactin? Now, what is macroprolactin and when is it significant is what I want to stress in this particular slide. So, basically macroprolactin, correct me if I am wrong, does not have a standard closed pack kit. What you have is a prolactin kit where there is a pre-processing of the sample which has to be done, and then macroprolactin is assessed with a ratio or a formula. That is the, what do you call, the glitch in this particular assay. Another thing is, we had a study of around 56 high prolactin patients where we saw that if we take a tri-pool sample of those patients, the values come almost in our study of 56, though it is a very small number, we saw the values come at least 60% lower in a tri-pool sample. That is my observation, I mean from our own data of 56 patients. The another thing which is very surprising is there are enough publications and papers about macroprolactin available, but they are not enough for us to derive what is to be done. So, it is basically applicable, there is a cutoff which we need to look at when we are reporting prolactin value, advising our patients to go for macroprolactin, because there is a lot of pressure with our gynecologists and infertility consultants. They start getting hyper about what is macroprolactin, what is macroprolactin. So, generally the cutoff which is followed is a value of tri-pool sample above 70, we are supposed to advise a macroprolactin test for that particular patient. Now, what is the treatment modality of the patient with macroprolactin, because we need to know that. See, basically if you look at this, the treatment protocol of that patient with macroprolactin is going to be almost same, but the follow-up of that patient, why I am telling you this is because it is more of a theoretical interest or it is of practical interest. It is definitely of practical interest if the value of total prolactin is above 70 in a tri-pool sample, then you can advise a test for macroprolactin. Again, there is no manufactured kit as on today. You have to use your prolactin total kit and do a pre-analytical or analytical combined procedure, and then go ahead with your macroprolactin and report it with a ratio. This is what I wanted to give as a message. Number 4, we took a case of missed abortion. Now what I want to talk here is actually AMH. So just tell me when the time is. Yeah. So I guess all of us who are advising AMH or processing AMH, are there challenges with everybody who is doing AMH in their labs? Yeah, because that's the reason we took this. Again, we did a data of, we had one very good presentation last year in our APPI conference, and that's what motivated particularly me to do this, because it was very troublesome. You do an AMH and there is a thing like AMH has to be, it's basically the, what do you call it, it's a fixed deposit of your ovaries. It gives you how much is the assured follicle. I am talking only pertaining to infertility. Definitely there are other indications of AMH, but AMH is the ovarian reserve of a female. when you are looking or investigating them for infertility, IVF, XYZ. So, and there is this hype of AMH and inhibin more than inhibin AMH, that okay, you do it once in a year, it is independent of the day of the cycle, not like FSH, LH or E2, and just be happy if the AMH is above an X value. I think I mean that's what clinicians talk about and go about, but there are challenges which I want to point out here. And what happens is, as on today, we are having 3 proved protocols, or I need not take the kit's name, but 3 diagnostic companies having the kits. Now what happens is, definitely there, I think what we did, we conducted a study of around 182 samples of AMH on a female, on a group of females with our known gynacs, and we did their AMH every month, knowing that it is independent of the day of the cycle on the second day of those particular females. We could do it for subsequent 6 months, like 1 month, 2 months, 3 months, 4 months, 5 months, 6 months. And we found a variation in AMH, which is, you know, definitely if you go to the statistical analysis, definitely there is a change. Now I have given here one data of my case, that's why, you know, it's just to point out that definitely AMH undergoes variations depending on your OC, you know, what is the female consuming, whether there is contraceptive pill consumption, whether there is endometriosis, whether there is hyperprolactinemia. Definitely there are some unknown issues, like people are claiming there are sample transportation issues, which we are validating, that if you keep AMH sample in the, say, refrigerator between 2 to 8 degrees, you know, and you keep it at -20, the stability of that molecule is better at -20. So that is where we are. If we are getting sample transported from long distance at a ice pack temperature, we know where AMH is. Definitely these are few of the pointers which I thought this would be a good forum, because we all are dealing with these challenges every day. We should have, we do not have precise answers, but yes, there are some data which we will be very soon coming up with, but positively AMH is not as stable as people or our clinicians or our papers say, and now there are definitely new papers coming up with changes and fluctuations and the reasons for changes of AMH. So this is where definitely these are all published variations, but imagine you get a call from your gynac and saying, okay, your AMH is changed. Can you say this? That definitely these are all published, but what is the reason? Your lab is giving a value of 4.8 and another lab is giving of say 1.8, there is a huge difference, isn't it? And if it is happening in 2 months of time, you should have the treatment history of that particular patient to justify why there is a change. And I think these queries are rising up every day, and that's the reason again this case was included in this particular presentation. We had a 32-year-old female coming for dual marker. Now this is one of the very favorite topic, but again extremely occurring very frequently, having all the details, and just you know the common thing what I normally say, where is the scan report? Believe me, this happens when I talk to our foreign you know speakers or people who come over to meet us. We say that they don't even come with CRL or NT, but that's what happens. And I think most of our time goes back asking the clinicians, please give us. Now this is what happens. If they say, okay, we have given you that data, you process, we have paid you. So that is what happens if you do it. So this is by an LMP method. I don't know if you can see those figures, but I have just scanned this report where you see the trisomy 21 risk is 1 in 191 because there was no NT or CRL. Now once we see a high risk kind of a report, there is a practice, then you again irritate your clinician and try and take the CRL and NT, and that's what, see what happens after that. The week of gestation is changed because what I want to highlight here is in a definitely dual marker is supposed to be done, not a triple marker, but still that's the trend. Definitely it is improving, and dual marker with a proper NT and CRL, very important, because that improves. And how precise the NT or CRL is. That's what I wanted to stress in this particular case. Again, this is very close to me because we knew this particular patient. He typical VIP syndrome kind of a patient coming to us with chest pains and symptoms, but definitely taken to a casualty of our adjacent hospital. Cardiac markers were asked, only troponin was asked. What we saw here is troponin was normal, if you can see, but we were in the process of validating HS. I mean, validating means we have this thing about whenever I have this new kit coming into my lab, I generally like to run it for 300, 400 patients and give them, like you give complimentary coupons, we give them complimentary reports to the clinicians, obviously, looking at what's the value add, what's the awareness of that particular parameter. So we saw a value of troponin I, borderline high. Definitely it's not significant if you look at the literature of troponin HS. So immediately we were all excited. We called the intensivist and we said, boss, troponin is borderline high. So he said, forget it, everything else is normal. And in his hospital, troponin was negative. So it was more important for him. But the patient was known to us and we said, okay, hold on, wait there for some more time. Anyways, we are not going to charge you. So let me have a look at his HS after some more time. And I think it's very nice to share these real-time experiences because you have actually made an impact to that patient and the clinician. And this was when the kit was just launched. So this is what we saw. I have given the timings that 4:10 the HS was borderline. After I think lot of convincing and cajoling and going behind the clinician, we got another sample, but then he said troponin he is only going to run. So we got HS which was almost, you know, ideal criteria or cutoff is 5 times, it is higher, and following next day, that is almost you can say 18 hours, we saw the value of troponin HS as 345. And mind you, the ECG level in these cases, I mean, we kept on getting that call, ECG is normal, ECG is normal. So I think what I wanted to stress here is the onus is on us equally to talk to our fellow clinicians and create awareness. This was just a very small first case when we decided to take this parameter into our laboratory. This was almost a year back, but I still remember and I thought I will get this to these four, you know, it's a best platform to showcase this case. So how we being interactive can help our patients. Yeah. I think here she was a young female who came with a severe pain in abdomen, had irregular menses. What we saw was right ovary was showing a single unilocular cyst. Now here what I want to highlight is CA125. The clinicians have, or we also, when we are asked what test should we do, we say CA125. So why only CA125 is not adequate? Because the specificity is not as good as HE4 is what I want to point out here. Where we look at CA125, it was 11, very well within the reference range. Okay. Look at HE, then we requested go for HE4, and this is what we saw in HE4. It was elevated borderline and the risk of ovarian malignancy and index was high. So, you know, obviously we have to, you know, the next question which comes up is, you know, why CA125 is normal? What is this new HE4? So I think everywhere what we as team are trying to drive the point is get aware and talk and find out and advise. Let the patient not come to you for HE4, but at least let the diagnosis or the right test be prescribed. Here HE4 is more specific for specificity of ovarian malignancies or basically than CA125, but the trend in our lab is say 80% of the tests are CA125 and remaining are HE4 or CA125 with HE4. So we have a long way, but that is how it should go. It should go as Roma and not just as CA125 when there is a suspicion of ovarian cyst. This is the last case where very known to me, where this is a CT chest, HRCT chest. You can see, I don't know if this, yeah, you can see the cavity here. She presented with, this is the chest x-ray. Yeah, housewife presented, no history of fever, weight loss or anything. Suddenly one day morning she comes with hemoptysis when she is brushing. The whole basin is full of blood and frank blood. Immediately you are trained genetically to collect the sample. She happens to be my mother-in-law. I rush and I collect the whatever is the frank blood. The first thing which comes to my brain is, okay, I need to rush this to Dr. Borges, because at the age of 63 that is what you are going to expect. So immediately we collected the sample, we took her chest x-ray and HRCT. Her routine blood investigations were run. With the sputum or whatever the hemoptysis was mixed like a double appearance, white and red. So what happened is, we don't trust ourselves most of the times. So we sent the samples in 2 different laboratories, and this is what we saw. If you look at the gene expert, that's what we keep on getting this, and I am sure you also are faced with sometimes these queries. We saw gene expert, MTB was detected and rifampicin was negative. Now interesting part comes here. This was the first sample. The second sample was rifampicin resistance positive. So the same patient having one episode of hemoptysis, where first particular discharge gave hemoptysis sample gave this report and the second is giving this report. So controversial reports, but actually that happened very early, and we referred her to one of the good chest physician, and we asked, because these are the questions which come to us also as a microbiology lab, that okay, you have given resistance, that other lab has given not resistant, or you have given not resistant and other vice versa. So does this happen? So definitely there are enough scientific papers to give that you may have a mixed population of bacteria or bacilli who are resistant and sensitive, both. But the case will be treated. Definitely what affects me when I talk to my patients or us is what is the difference in the treatment. The difference in the treatment is what should matter. Here she was treated as a resistant MDR case, and of course the follow-up was done after 9 months and resolved now. So I think with this I will like to actually stop my presentation. But I thought of getting those challenges, instead of getting into theory, I felt those things which we face in our day-to-day lab as a reference lab or as a single lab, what are the questions which clinicians ask, to put it forth in front of you all and try to create awareness and search for more solutions. Thank you so much.